I know this one, we're slap bang in the middle of
half term,
aren't we? So people are off work. There was, as I said, 60 people signed up for it, all of whom will get the link afterwards as well. So, and these links are to share with people that you think may find this beneficial as well, because our aim is to just get as much information out to as many women as possible. So welcome everybody. We'll kick off as it is 1 o'clock and we know it's lunchtime. So thank you again to you for being here, but also to the Hertfordshire Health Protection Board and Hertfordshire Better Business for All, who have funded this series, which we called Moving Through Menopause, which is really just about giving you as much information on the body, on the mind, on the breath, on absolutely everything that covers menopause, because it touches every part of a woman's life, internally, externally, and relationship speaking as well. And the bits that we're going to go into a bit more depth about today are provided by GP nurse Kate, and her social media is called Talk Menopause with Kate. Is that right?
Yeah.
Kate? Yes.
Very simple.
Yeah, and I know through experience and working with women currently that because since the beginning of lockdown, the menopause conversation has got so much louder, which is fantastic. I do know that obviously HRT became a little bit more difficult to get hold of, because the demand went up for it. But there are still lots of questions about whether we should be on it and what is it. So that's definitely one area Kate's going to be talking about, because I think as well, what is also happening is that people are finding it perhaps a little bit difficult to get an appointment with their local GP, or perhaps the local GP isn't as knowledgeable about the topic as they feel they should be. But alongside that, there's going to be lots of other stuff about menopause in the workplace and sexual health and everything else. So I won't go on much longer. I'm going to mute myself. Please leave your chats or questions in the chat function, either to the public group, or if you want to ask something anonymously, then you can post it to myself directly, which is, I think I'm under Face Fit Woman, and I will filter those through to Kate at the end. So over to you, Kate. Thank you.
Thank you. Hi everyone. Thanks for joining us today. So I am a GP practice nurse, and I specialise in women's health. So mainly doing everything to do with menopause, sexual health, smear tests, family planning. That's generally my bag. So here's just a little bit more about me and my background. So as you can see, I've been doing menopause health since 2010. Back then, I would probably only see one lady every few months, and she was generally probably a postmenopausal lady. Now I see roughly about anything between 15 and 25 women a day, and you can be from anyone who's in the perimenopause all the way up to way postmenopause. I've got my ladies in their 80s who are not willing to give up their HRT, and they love it. So I'm a nurse prescriber, so I also can prescribe medication, and I'm a member of the British Menopause Society and a member of the Faculty and Sexual Reproductive Health. So as Emily said, today I'll be talking about some signs and symptoms of menopause, the treatment options, benefits and risks, menopause in the workplace, HRT and family planning, because they still go hand in hand, general women's health, and you've got some time to ask some of those questions at the end. I'm not going to go into too much detail about what menopause is, because in the last few webinars we've talked quite heavily about that, and I'd just be repeating a lot of what was already said, and I think a lot of people now know. But when I first started doing these talks, if I was to Google menopause, these are the things that would come up, and they're quite offensive, I think, some of them. It doesn't make menopause seem like a good time of your life at all, which I know for a lot of women they do struggle, but also we don't have to feel that we're these awful things that and our life's over if we go through the menopause. And I talk about later about how the people like Davina are making it a lot more positive, making some positive steps, and we shouldn't be embarrassed about going through the menopause. So here are just a few statistics about menopause, just some simple facts. So 8 out of 100 women tend to stop having their period, so cease menstruation, before the age of 40, and that's naturally. 5 out of 100 women, they continue until the age of 60, and I always feel really sorry for these women, because they're like, when is it gonna happen? All their friends have gone through it and they're still waiting. And then 51 is your very average age. A lot of my information will be sort of NHS based. I work for the NHS. I base a lot of my information from based on working as an NHS nurse. So I don't talk too much about what goes on in the private sector, because it can be very different. But interestingly, women who smoke, they tend to go through menopause earlier than the non-smokers. I don't know if that's something to do with health. But yeah, that's apparently a true statement. And in 2017, they, Age UK, they stated that, from the age of 65, a woman was going to live for another 20 years beyond that. So if you go through your menopause in your early 50s, then you could be in that post-menopause stage for over 30 years. And that's actually a really long time. And for some women, their symptoms don't always go away. So these are just a handful, and I say a handful because there are hundreds of symptoms of the menopause. And I'm sure, a few of you, if you're looking at this, you can sort of go, yeah, got that, can relate to that. There's so many things that aren't on there. Are reflux, acid reflux can also be exacerbated in menopause, and also tinnitus, which is a new thing that we're looking more into. But there is that you can use apps to help log your symptoms. There's a really good one called the Balance app that is designed by Dr. Louise Newson, who is part of the Menopause charity. She designed this app, and it's really good at logging your symptoms. And then when you decide you want to have any treatment, or you want to go speak to your doctor, you can then go with a printout of what you've been going through, when, and it's kind of half the consultation done. So it's really good. And it helps out the GP as well. And also on the app, it's got lots of information about menopause and things you can do yourself at home. So just some of the basic treatment options that we've also talked about on the webinar series is, lifestyle, exercise. I know Emily spoke about that last week. Exercises such as yoga, Pilates, muscle strengthening workouts. These are really, really good for menopause. Things like yoga and Pilates are good because they're also focusing on relaxation. Maintaining a well-balanced diet. We learned about that with lots of protein, complex carbohydrates, healthy fats, low sugar, low in processed food, reducing your alcohol, and weight management, and stopping smoking for just general health and well-being. Practicing relaxation techniques, meditation and cognitive behavioural therapy have actually been proven to really be helpful towards menopause symptoms such as hot flushes. I'll talk about those a little bit more in detail over the next slide. And then you've got your over-the-counter and herbal remedies. Again, I'll talk about these in more detail. Complementary and alternative therapies, vaginal moisturizers and washes, and good old HRT. So CBT, so cognitive behavioral therapy. So as I said, it can help improve symptoms such as anxiety, low mood, and also it can help ease hot flushes and night sweats. There has actually been quite a bit of research done into this, and some studies have shown that it really does help. And I'm just going to read from my notes here. A North American study that was done recommend that CBT helps combine relaxation techniques, and is provided a fact sheet for women, which is guidance on CBT, and this is you can find on menopausematters.co.uk. Some of the herbal treatments are also very good. I always recommend that you do, I can't go into too much detail about them because they're not generally not regulated, and no research, limited research has been done on them. But if you look out for the THR logo, generally that means it's had some sort of regulation attached to it. But things like black cohosh and St. John's wort, these are very good for mood and flushes. However, they can affect your liver. So always, if you're on other medications, always make sure that you check with your doctor or the pharmacist before you take them, because they could stop other medications from working effectively. We know for sure that St. John's wort can stop, for instance, the contraceptive pill from working. So just always be mindful of that. You've got some soya product, isoflavones, soya products, red clover. These are also said to help with the vasomotor symptoms, the flushes and the sweats. However, again, these aren't recommended in women who have had breast cancer because they could have estrogenic effects. So again, always check with your doctor before taking those. Acupuncture, we heard that that's, it's documented as being a high placebo effect, but I've known quite a few ladies who have had it and they find it really does help with those hot flushes and the night sweats. So it's really the more sort of physical effects of menopause that you can get day to day. And then you've got the vaginal moisturizers and washes. I'll list those. You've got ones called Replens and Vagisil. These are very good. These are just over the counter. There's no hormones in them. And there's one called Yes, which I don't particularly like the name of it, because what is that saying? But it actually is well received. It's very good. I've got quite a few patients who use it and they quite like it. Just as I say, a moisturizer and a wash, and they find it does help with that vaginal dryness and soreness and itch. And then for your kind of sexual lubricants, you've got your Durex clay and something called Silk, SYLK. That's very good. I would try and avoid things like KY jelly. They're water-based lubricants. They dry up very quickly and they just end up sort of chafing, for a better word, and not helping with the soreness. But I do always recommend that if you are suffering from vaginal symptoms and you are going through the menopause, always get that lubricant involved from an early stage, because it will always make things a lot more comfortable. So hormone replacement therapy. So treatment, NICE have said, and although that's 2015, it still stands today that it is the first line treatment for menopausal symptoms. So as medical professionals, we are advised that we are allowed to prescribe it. And it doesn't say what symptoms, it just says for menopausal symptoms. The way it works, it replaces hormones in the body, what the body is withdrawing from, so your estrogen, your progesterone, and also testosterone. And for majority of people, the benefits outweigh the risks. There's very, very few people women who can't have HRT. And for the most, it's all about quality of life. The safety of HRT is, as I've said there in bold, is largely depending on age and length of use. So for we always recommend, we all start out with the lowest dose needed to control symptoms for the shortest time needed. Generally, I would say anything between 2 and 5 years. And then, we always then have that discussion as to whether you want to carry on or whether you want to try weaning off and stopping. We always sort of say, don't stop dead, just gradually come off. So if you're on sort of a tablet a day, you then eke it out. So you do one every other day, and that's just, and then spread it out from there on. And as I say, with the lowest dose, we can always build up if we need to. But generally, if you're going to start HRT, nothing's going to generally change in the first couple of years, and you would want to carry it on for at least, as I say, 2 to 5 years. So approximately in the UK, apparently there's about 1 million women are on some sort of form of hormone replacement therapy at the moment. And prescriptions have more than doubled in the last 5 years. And as I say, I can definitely vouch for that in my own job. And I can say that, I'm prescribing like it's Smarties at the moment, which is good because the information is getting out there and women are now not so scared. So treatment options do depend on the woman and their needs. So if a woman has their uterus, they would require a combined treatment of estrogen and progestogen. The progestogen component is like a womb sort of lining protector. So it plays a really important part, and it helps control any bleeding, because in our natural cycle, the estrogen comes in, thickens up our womb lining, and then the progesterone comes in and that thins it out and we have our period. So with HRT, obviously you've got the estrogen going on all the time, and then you have that progesterone component that comes in just to keep that womb lining thin, and then you don't get any bleeding or endometrial issues. With the combined therapy, it can come in tablets, patches. You can separate your estrogen and your progesterone, and you can either take it depending on what stage you are in your menopause. If you're postmenopausal, then we recommend that you have a continuous therapy, so you have estrogen and progesterone all the time. And if you're perimenopausal, so you're still having your periods, or they might be a bit infrequent, but you've had a few in 1 year, then we would put you on sort of a sequential therapy where you would still have, you would be bleeding most months, but it would be on like a cycle. So you have the estrogen all the time, and then your progesterone is introduced for 12 days to 14 days of a cycle. And then for a woman who's had a hysterectomy, so there's no womb, you just need estrogen only. And that can come in tablets, patches, gels, or spray. So if you have read the media, you will be aware that the gels and the spray are quite tricky to come by at the moment, but it is getting better. I'm hopeful. The thing with HRT is, you should always speak to a medical professional, whether it be your GP or practice nurse, and it should be prescribed safely and correctly. But otherwise, as I say, pretty much most people can have it, most women can have it. You can also have a vaginal cream. It's a hormone-based cream that can work alongside your normal HRT. So where you've got estrogen and progesterone going on a combination, if you wanted to also, if you had that sort of vaginal dryness, itching, what we call vaginal atrophy, then you can also use a separate estrogen cream alongside your HRT, because it's very localized to the vagina. It doesn't go into the bloodstream and shooting around the body, so it's very safe to use. Or you can just use that on its own if that's your only symptom. And then there's also testosterone gel that I will talk about a bit more later, but that can also be used alongside an estrogen-based therapy. So when I said about the progestogen, when you can have it separately, you can have it in tablet form or Mirena coil. I know that a lot of people are scared when I say Mirena coil, the faces I get sometimes of dread and fear, but actually it is really, you know, it works beautifully as part of a HRT regime. You know, there's lots of people out there who think it's gold standard, you know, it helps with any bleeding issues. I mean, that's why it was designed way back when, and it works as a contraceptive if that's needed as well, and it's long lasting, so it stays in for 5 years, so it's got a lot of benefit. But then there is also progesterone tablets out there. There's your sort of synthetic progesterone tablets, but there's also a new one that's come out, I would say in the last sort of since 2019. We know a lot more about this tablet because there was a massive HRT shortage back then, and it's called Progestogen. It's a micronized progestogen, so it's as close as we can get to natural progestogen. And again, the regime you take with that would be depending on what stage you're at in your menopause. There's also estrogen treatment, which comes, as I say, in tablets, gels, patches, and spray, and your localized vaginal creams. And that comes in, creams, tablets. You've got a ring that you can put in, and that stays in for 12 weeks, or you've got a pessary, and depending on, again, your needs is how often you would use these. And then you've got your testosterone gel. So with the gel, on the NHS, we prescribe it alongside HRT for reduced libido, but this is an off-license medication. The reason I say that is because the testosterone we've got in the UK is only ever been tested on men, and it was designed for men. So you get a sachet, and whereas a man would use the whole sachet every day, obviously that's going to be too much for a woman. So a woman would use a teeny blib just every day or every other day. In the private clinics, I do know there is a female testosterone called Androfen, which is been designed in Australia, and they can bring it over, because if you're going to pay for it, you can get these things. But on the NHS, we are limited to the testosterone gel, and we are limited to prescribing for reduced libido only. So when you're on HRT, you can get initial side effects. It's very common. The initial side effects tend to be bleeding, not heavy, just very, very light, and breast tenderness, a bit sort of premenstrually. These are very common in the first 3 months. So if you get anything like this, if you do start HRT, don't think, oh, it's not for me, this is how it's going to be. They do wear off. I always give a 3-month prescription, and generally by that 3 months, the woman will say, I was feeling that, but it's now eased off, or things are getting a lot better. If you are going to get like the longer term side effects, it could be that particular HRT dosage or regime just isn't for you. So you've got, the estrogenic effects, which are fluid retention, breast tenderness, bloating, nausea, headaches, and then the progestogenic ones, which again are very similar, but you put a bit of mood swings and PMT like symptoms in there as well. But again, as I say, these are generally temporary and do ease off. So benefits and risks. So with the benefits, obviously the main one is relief from your menopausal symptoms. It's very safe to use, as long as it's prescribed safely and by someone who knows what they're doing. And it can play a role in, prevention of osteoporosis, cardiovascular health, mental health, we now know, and also they're doing an awful lot of research into prevention of dementia. You know, they're now looking and seeing that actually they think women who have had a course of HRT at some point may be reducing the risk of dementia in the future. And as I say, a lot of women can take it, the benefits outweigh the risks. Now, there are some risks, obviously, because it's a medication at the end of the day. There is a very, as I say, there's this slight risk with breast cancer. However, I'll talk about that in another slide because I've got a lovely sort of diagram that explains it. And obviously possible small increased risk of DVT or stroke. Now, this is because it's estrogen. Estrogen can thicken up your blood and cause blood clot. Now, if you have oral estrogen, the risk is slightly higher. The transdermal estrogen, so through the skin, your patches, your gels, your spray, the risk really isn't increased at all. But whoever prescribes it will always make sure that they're doing it safely, your blood pressure's fine, and you know, you're not a migraine sufferer, and look at your family history and your own medical history and prescribe it as safely as they can. But as I say, you know, the reason we prescribe is for, or you know, the advice is for the lowest dose for the shortest term. Now, the studies that were carried out in the 90s, which caused all the fuss, and that's why all the women suddenly were taken, or they stopped taking it and their GPs refused to prescribe it, you know, was something called the Women's Health Initiative study. It was done in mostly studied on North American women, and they were studying the ladies in their mid-60s who were probably generally overweight and didn't represent the women of the UK who were going to be taking HRT. You know, we all know that the breast cancer risk naturally increases when a woman, as a woman gets older. So since then, you know, further analysis was done and more studies were done. And then there was one called the Million Women's Study, sorry, get my teeth back in. And that showed that there was no increased risk of breast cancer if a woman takes HRT for 10 years. And then, so that was really positive, and that was a huge turning point in women's health. And then there's been a study in Denmark that in 2012 that demonstrated very positively that it helps towards heart disease and stroke. So that's good. So lots of benefits for the body. So this is the slide I was talking about. And this is an oldie, but it's quite a goodie. I don't know if anyone of you saw the Davina McCall documentary. She used this and she used a big sort of ball pit as her analogy. So as you can see here, per 1,000 women between the ages of 50 and 59, it's the breast cancer risk. So generally in the UK population, you'd get 23 cases. If you introduce HRT, so a combined HRT, 4 extra cases. If a woman's on estrogen only because maybe she's had her hysterectomy, it actually, I think there's fewer cases of breast cancer. But as you can see here, you know, if a woman drinks 2 units a day, the risk is even more. And women who have a BMI greater than 30, is 24 extra cases. So if you compare that to if you think about how many women are overweight compared to the women who just take, you know, compared to the HRT, it's quite a, you know, you're much more at risk of getting breast cancer from being overweight than you are from taking HRT. And remember what I said about that study that was done in America, and you can see that, you know, the risk was more likely because the women were older and overweight. But yeah, there we go. So menopause, big news, as we all know. So, you know, as I said before, you know, Davina and Lorraine and is it Penny Lancaster, they've all been really good at making, you know, headlines and making sure that we talk more about menopause and HRT. and they've been doing a grand job. And, you know, we now are much more aware. I think, you know, way back when, even just 10 years ago, you know, in women in their 40s, or even possibly 5 years ago, women in their 40s, they weren't aware so much of the symptoms that were creeping in, and they were just, you know, people were leaving their jobs, their relationships were breaking down. And I think we now recognize these symptoms a lot more, and we know to get help, or, you know, start doing treatments, looking after ourselves a lot more now than we did even 5 to 10 years ago. And also, you know, the government's recent decision of, you know, reducing the risk, reducing the cost of HRT. So it's not come into play yet. It comes into play April next year. It was meant to this year, but it's been put back. But it means that you can get a year's prescription of HRT on one prescription charge, and that's huge, because it was costing a small fortune for a lot of women. And as I said about the Balance app earlier, there's a lot more on sort of social media, a lot more on TV. You've got Dr. Louise Newson, who does a lot with, you know, seems to be on Holly and Phil's couch every week, chatting about menopause and the risks and the benefits of HRT. So a little bit about menopause in the workplace. So in 2019, the British Menopause Society said there was over 4.3 million women employed in the UK between the ages of 45 and 60. And, you know, if you think about that, and you've got women here, you know, more than 1/3 of women have stated that the menopause impacted their work life. That's huge, isn't it? And then, you know, where is it? There's something saying that there's women who, the amount of women who quit their job, here you go, 10% of women quit their job because of menopausal symptoms. I mean, it just shouldn't be happening. And I feel quite passionate about that, actually. You know, and this is where HRT can really help turn things around. You know, if you're not sleeping, you know, you're never going to be able to do your job if you've gone, you know, days with hardly any sleep. And if you've got, you know, 50% here saying that it affects their home life, if your home life's affected, then you're not going to be concentrating so well on your job. You know, there's lots of different things there that can just affect you doing your job to the best of your ability. And it's all due to these little menopause symptoms that keep creeping in. And in being too embarrassed to tell your employer why, you know, you may need to take a sick day, and not being able to ask to go for GP appointments. I think, you know, there's a lot that could be changing here for employers to help with the ladies. And as I say, you know, the symptoms, they last for, you know, anything between 2 and 5 years minimum. So it's not like a short-term thing. You know, these women are going to be trying to work while in this state. So what can you do in the workplace? Well, it's not rocket science, really. You know, just be aware. I think it just boils down to being kind and understanding. You know, I do a lot of these talks, and recently I've gone into a few workplaces and actually talked to men and managers, and done separate talks for men and managers. But it's all about raising awareness, providing information to all staff, not just women, understanding that a one-size-fits-all approach is not appropriate. Maybe having a menopause champion who, you know, someone could, you know, people can go to and just chat to if they're struggling about anything. Although, you know, I still believe this, you know, you shouldn't have to have something like this if you've just got a nice understanding workplace. You know, you shouldn't have to have like a menopause policy, you know, allowing time off, but, you know, it helps if you do have something like this, because then you can maybe bring in something like flexible working. So if a lady hasn't slept all night, does she really need to sign on to her computer by 8:30, 9 a.m. that morning? Could she maybe sign on at 11, so she's had a few hours just to maybe have a few hours extra sleep, and then maybe it's better for her to work a bit later in the evening, just being a bit more flexible. And then just also not discriminating. Just because a woman's a certain age doesn't mean that she's going through the menopause and struggling with the menopause. And so, the whole like, oh, it's just her age, ignore her type of thing isn't helpful either, because actually she may be well justified in behaving the way she's behaving. And also just allowing adjustments in the physical work environment. So desk fans, moving nearer to a window, so or even closer to a bathroom. If you've got a lady who's having this awful perimenopausal flooding, or needing to go to the loo a lot more, just little things like this will be a lot helpful and make someone a lot more comfortable. If your colleague just needs to take 5-minute break out in some fresh air, just don't question it, just let them go, and don't sort of, where have you been, what have you been doing? Just let them take their 5-10 minutes just to compose themselves, get over their flush or sweats or whatever, and then come back in. So as I say, that in the workplace, it's not rocket science. It just needs to be a bit more understanding. So family planning and sexual health, they also, a lot of people think, oh, well, if I'm going through the menopause, I don't need to worry about any of that. But you do, because, as I said, your perimenopause symptoms are coming in your 40s, early 40s likely, and therefore you could still easily have a baby. So that's where, you can have family planning and HRT working alongside each other. As you can see here on the graph, things are, dropping off a bit, but, it doesn't mean it's not impossible. So with contraception, generally for most women, it's still required until the age of 55, or at least until a year after your last period, if you're over the age of 50. If you're under 50, then we'd say 2 years after your last sort of period, just to err on the side of caution. But generally by the age of 55, 96% of women will be 1 year postmenopausal. And so we feel pretty safe stopping. Family planning is so more to do with family planning, combined hormonal contraception. You've got your pills, your patches, your rings. These are all fine for under 50s. There's no risk factors, but remember I said about the estrogen and the increased risk of blood clots, so we tend not to prescribe those things to women over the age of 50. But you've got lots of progesterone only methods. You've got the pills, the coil, the injection, and the contraceptive implant, and you've also got your non-hormonal methods there, your coils and condoms and things. Now, I didn't, I was a bit shocked by some of these statistics with the sexual health side of things, because in 2020, obviously we had this big lockdown, and I was like, what? Who are these people? Who are they meeting, and how are they getting STIs? Because I was stuck in my home. But in the older age group, so they're less likely to engage in safer sex. Because they just think, well, I can't get pregnant, so it's fine. But what they don't realize is they are actually, women particularly are more vulnerable to STIs because of the pH levels in their vagina, and less vaginal secretions, you're more risk of sores and tears. So STIs do tend to go up. But I was quite impressed by that figure of 22,000 were newly diagnosed in 2020. Over the age of 45 to 64-year-olds. And just a reminder, just generally, that for to always go for your screening when you're called, so your mammograms and your smear tests. You mustn't forget those when that letter comes through the door. Thank you for watching. And this is sometimes how we feel and how people see us, but we really are Wonder Women. Thank you very much.
Thank you, Kate. Thank you. And just following on from that last point as well, actually, I don't know whether I should be saying this or not, but obviously the new thing that's come about with the media and is monkeypox as well.
Yeah.
Now as well, you know, if you've got those symptoms, you have to wear condoms for up to 6 weeks, I think.
Oh, yeah.
And things like that. So yeah, being really mindful and aware, again, that word, being aware of what's around.
That monkeypox looks a bit scary, doesn't it?
It does. But right, so that was just, sorry, front of mind. So I am just going to go through these questions. So the first is one to do with replens, and somebody has noticed and had spoken to another person that they've experienced a reaction to replens, painful irritation and redness of tissues. Is that something you hear of?
No, that's not anything I've come across, but obviously with any, you know, moisturizing, you know, for some people one thing suits and the other person it doesn't, but no, it's generally because it's got nothing sort of too crazy in it. It's very basic and that's what we want because of the pH levels and things. You want it all very plain. It's just to help ease and moisturize, really.
Right.
But you know, yeah, sorry to hear that for the other lady, but hopefully, you know, if you try it, you'll be fine.
And is that perimenopausal advice specifically? Because I know I've always read things like don't use anything scented or soaps when you're washing your vagina.
Yeah, I mean, do you know what? We say that all to everyone, no matter what age, because of what happens in the vagina is, even if you're in your 20s, you've got your two sort of, sorry, brain fog. You've got your two sort of, you've got your good bacteria and your bad bacteria. And what happens with these washes is they can wash away all your good bacteria, so you've got nothing then to fight your bad bacteria. These are all very normal things. It's not like anything sexually transmitted or anything like that. But then if you've got an overgrowth of your bad bacteria, then you can get things like BV, which can be quite unpleasant for some people, like heavy discharge, odor, that kind of thing. So the running line for women's health is just water. Don't wash, don't use anything down below. Obviously, if these are different because they're actually specially for vaginal symptoms, vaginal washes, but generally you shouldn't need anything crazy.
Okay, all right, thank you. So this is an anonymous one, which is from someone who is 51 and not had a period since the end of last year.
Sorry, Emily.
Oh, sorry. Can you hear me?
Yeah, you broke up for a little bit then.
Yeah, sorry, I don't know what's happened there. So this person is 51. It's doing it again, isn't it? And not had a period since the end of last year, has been experiencing symptoms for 6 years, but didn't realize it until about 2 years ago, has never had children, has fibrocystic breast disease, only been able to discuss symptoms over the phone with a GP, and they've offered just one option, which is HRT with a Mirena coil and a patch, which she doesn't think is right for her, but they say it's the only option on the NHS. And she's just worried, I think, that the coil is not used for longer than 2 years.
Oh, okay. No, the coil can be used for up to 5 years. But so the GP's only said that that's the only option.
Yes.
For her. Okay, I can't see that question on.
No, sorry, it was a direct.
So no, it's not the only option. if she needs HRT, there's you know, as I said, you've got a combination patch that can be used. It's got estrogen and progesterone in the patch. If that's what they're mainly worried about, they don't want her to have the oral HRT for whatever reason, then, you know, the transdermal, so through the skin, is perfectly safe. And as I said, there's the tablet, the progesterone tablets that we take, and they're kind of natural progesterone, so they're even more safer. And yeah, you just take those, you know, depending on, as I say, did you say she had her period at the end of the year?
Yeah.
Yeah, so she's still not quite that year yet. So, you know, ideally a sequential therapy would be better.
Okay.
For her right now. So, you know, you just have your estrogen therapy, and then you bring in your progesterone for 2 weeks of the month, progesterone tablets. But yeah, no, you don't have to have a myelin coil. There's lots of other things out there.
Yeah, and I think as Abby said to everybody, that there is historical horror stories. She did her research and spoke to a nurse and has had one for a year, and it's been great.
What nurse did you speak to, Abby? So I know Abby.
Ah, you do know Abby. So yeah, there we go. Because I know I've been suggested it before, and my initial reaction, my instinct is to go, oh no, recoil from the coil almost.
Yeah.
And I don't know why. It was you, Kate, she spoke to, funnily enough. And I couldn't tell you why, but it is.
I've always been because although I've had children, I didn't have vaginal deliveries. I had 2 cesareans for one reason or other. So I was always very scared, and it didn't help that when I had my smear tests, my nurse would go, oh, you've got a tiny cervix. And I'm like, oh. But because of periods and things, I have, you know, personally chosen to go down that route, and it has helped. It really has. And it didn't, you know, I had to have it done, you know, fitted at the hospital, but it was actually, I came out of there sort of jumping, because it was a much nicer experience than I was anticipating. It wasn't, the ladies at the clinic were lovely, and they really put me at ease, and I wasn't in any pain or anything. So really anyone can, you know, it really can be for anyone. But there are the horror stories out there, but I work, you know, I attend and help out with a coil fitting clinic every week, and all the women walk out, they're fine. You know, we're not calling ambulances or anything like that for these ladies. They will happily leave the building. So it is uncomfortable, I'm not going to lie, but it's not scary.
And I think it's going back to that quality of life. I've trained women who've had to stop working out because they are flooding and don't know when. It could be in the middle of an M&S, it could be in the middle of a strength training exercise class. So yeah, it's kind of, you weigh those things up.
Yeah.
Right, I'll go through these because there are some coming through actually. So I am 51 and have many of the symptoms for a number of years, but told my bloods don't point to menopause. I've heard this before. But my neurologist says it's probably menopause. I'm recently diagnosed with epilepsy, and I'm unsure if the symptoms are epilepsy or menopause.
Okay. So yeah, we don't do blood tests on women over the age of 45. There's no point really, because it's not going to tell us anything we don't know. Yes, you're either perimenopause or you're postmenopause. It's not going to tell us either way. You know, and it doesn't change the treatment. If I had a lady coming to me who was under 45, it would be different, because maybe I'd want to have a look at other things just to make sure that nothing underlying was going on. But generally, over the age of 45, not a problem. I can't obviously talk too much about your epilepsy and things, because that's not my expertise. But you know, I do know that I've got women who have epilepsy who are on HRT, and it's fine. I always make sure that their neurologist is happy before I prescribe it, but generally it's not a problem. Because the medication, and also they prefer the transdermal route, again avoiding that liver, because if your epilepsy medication could they could discount each other. So like the epilepsy medication could stop the HRT from working properly, and vice versa. So it's all to do with the liver and how it's all processed in the liver. So I would always recommend through the transdermal route initially. But it would be hard to say, obviously, because you're not a patient. I wouldn't be able to say for sure what's menopause and what's epilepsy related, but there's no reason why you couldn't, you know, providing your neurologist is happy, there's no reason why your GP can't prescribe HRT if needed.
So keep digging, and
don't
worry about the blood
there's
test.
Lots of GPs can always ask for advice and guidance, and it's always just a quick ping off email just to ask. It doesn't even need to be specifically to your own neurologist, you know, just to make sure that, you know, they can't see any reason why not.
Okay. If you can't take, if you can't take the combined pill, does that mean HRT won't work for you? No,
they're different. They're completely different. It's fine. It took me a long time being a family planning nurse to get my head around that at the very, like 10, 12 years ago. But no, they are completely different. If you can't have it in the contraceptive pill, the estrogen component is ethinyl estradiol, so it's synthetic, whereas in HRT it's not. It's estradiol, which is more natural. Okay. So it's very different. So you know you're fine to have it.
Okay. I'm 51 and still have a regular period. Is it possible to go through menopause without any intervention? Are there women out there that glide through menopause easily as if they have good overall well-being?
Oh, right. Okay. Sorry. Let me just, can I just point to the last question? Again, I don't know why you can't have the contraceptive pill, but there may be a reason I don't know about. But there shouldn't, you know, if, you know, but generally you can have it. Yeah. But again, speak to your doctor. Sorry, can you say that one again, that question?
Yes, sorry. I'm 51 and still have a regular period. Is it possible to go through menopause without any intervention? Yeah. Are there women out there that glide through menopause easily if they have good overall well-being?
Absolutely. Yep. Yep, of course. You don't have to have HRT. You know, I get a lot of ladies who go, oh, I think I might be going through the menopause. I've come for my HRT. And I'm like, well, are you having any symptoms? They're like, not really, nothing I can't cope with. You know, I feel quite happy, I'm fine. I'm like, well, that's fine. Remember, HRT is for treatment of menopause symptoms if you need it. If you're thinking, yeah, I don't like this, I don't want to, no, I'm not happy with what's going on, I want something. But you generally, if you lead a healthy lifestyle, you don't need to. You're as in, like, you know, you're making sure that you're getting good, you know, your calcium, you're exercising, you're doing everything you can for bone health and general well-being, then yeah, you can glide through it.
Somebody was wondering how they can access the group Cbt course, Managing Hot Flashes, developed by Myra Hunter and Melanie Smith.
Ah, yes.
Free via the NHS. Is that available? Can she refer herself, or has it got to be done through GP or menopause clinic?
I think the CBT has got to be done through the menopause clinic, or the GP has to refer you. They do like a self-help guide that you can, you know, do yourself. But generally, I think you need referring for these things. Unfortunately, the British Menopause Society, well, not unfortunately, they do CBT courses for nurses and doctors to help with menopause, but it's incredibly expensive and it fills up really quickly, and they only do it once a year. So I'm going to try and get on one next year. But yeah, generally you need to be, I think, referred to it, or go, you know, go on to the self-help one, the guide that she wrote.
Okay. I hadn't heard of that. I'll look into that as
Mm.
well. Somebody has just commented, I have epilepsy and have been on HRT for a number of years successfully. So, and somebody direct messaged me about a question I asked earlier about how they were just offered kind of one option and nothing else. From what I would say, personally speaking, would be is to ask your clinic whether there's a menopause specialist GP within the practice, because I know that Dr. Louise Newson has kind of produced this elective module now, hasn't she, that a GP can take within a practice. There might be somebody that might have a little bit more information, maybe a different view on it. I would say just keep talking and keep asking for different people to speak to.
Yeah, there is generally going to be someone in the set. I mean, in my surgery we are very lucky because there's me, but also I work with 2 female GPs who are also really heavy women's health specialists, but generally there should be someone around. But if not, there is always the private clinics, but I don't, they cost, obviously, so I don't like to push them too much, because you shouldn't have to use them, and you should be able to just go to your GP. But it's getting better. It is getting better, and so hopefully, do keep pushing though.
Okay. How do you know if you might benefit from HRT if still having periods? In other words, that you just have PMT?
One, is it cyclical? Are you getting it just, premenstrually? And 2, because if you're having it all, month long, your flushes, your sweats, your whatever, your mood or whatever, then you know that it's probably perimenopause symptoms. If it's sort of if it's premenstrual, then something more like a contraceptive would help with that, rather than HRT.
Right.
Because I would always be a bit cautious starting it too early on, if it is just PMT, because
yes,
you may end up getting more side effects.
yes.
Then where do you go from there?
I once heard Dr. Louise Newson say something about there is a magic window when to start HRT. Do you know what that is? Is it, your periods are very irregular, or you've stopped completely?
Well,
or is it very individual again?
Yeah, it's one of these things, because you do get the women who everyone's different. So everyone's magic window will be very different. You get the ladies who periods all of a sudden stop one day, and they didn't have any symptoms, but then the minute their periods stop, bang, they get all the symptoms. But then you've got the ones who it just creeps in and the periods start to mess about a bit, whether that's they become heavier, or they longer apart or closer together. I would always say though, if your periods are changing, as in they're getting worse, whether that be flow or length of cycle, please go and see your doctor, because it may be, you can easily go, oh, it's just the menopause, I'm just that age, but actually you may have like a fibroid or something. It might be worth just going to get an ultrasound scan just to make sure that everything's okay.
Okay, that's great.
But yeah, the magic window thing is probably when things just start to creep in.
Okay.
Yeah, when those symptoms start happening a bit more frequently.
This is a minefield, isn't it? This area, and it's so under researched and still, and yet to me it blows my mind, all these different hormones that we can take and the different ways we can take them and the levels at which we take them and the age at which we take them. So thank you for kind of and giving us that information and talk, hence your name, it's talk, isn't it? Talk about it.
Yeah.
And keep digging for that person in your practice, it would be my advice. And don't stop if you're suffering and your quality of life is suffering.
It's no fun, and you shouldn't have to go through it.
No. Thank you.
It's okay.
Thank you
everyone for listening.
For being here, and I'll send through the link for this talk, and if you would like others, then please get in touch with one of us and we can send it through to you. Thank you. Take care. Have a lovely long weekend. Bye. Thanks, Abby. Thank you, Lee.
Bye.
Bye.